Ladies and gentlemen, if we could come in and take our seats, we'll begin the last panel for this afternoon. Tell Jay to get the doors closed. Yeah, close the doors. Ladies and gentlemen, we're going to begin our last panel session of this afternoon. The next panel is entitled Key Saudi Healthcare Sector Enablers. And our moderator for this panel is Mr. Charles Halab, who is a partner at the law firm of Mayer Brown. Charles?
Thank you. Thank you, Ed. Good afternoon, Excellencies, ladies and gentlemen. As Ed said, my name is Charles Halab, and I'm a partner at the international law firm of Mayer Brown. It is my distinct pleasure to moderate our last, but certainly not least, panel today about enablers of the Saudi healthcare sector. It is my profound honor to be exploring this topic with such a distinguished panel. Dr. Mahmoud Al-Yamani, CEO, King Fahd Medical City; Laurent Dubois, Vice President and General Manager, GE Healthcare Partners; Dr. Rana Al-Mandil, Director, Quality and Strategic Planning Administration, King Fahd Specialist Hospital, Dammam; and Mr. Tal Nazar, Managing Director and CEO, Bupa Arabia. When they asked me to host this panel, I don't think they knew that one of my very first childhood memories is that of visiting the doctor in 1975 Riyadh. Much has changed since then, both inside and outside the Saudi healthcare sector. But what remains constant is the unrelenting perseverance and progress that defines the Saudi Arabian healthcare sector and indeed the Saudi Arabian spirit. With Saudi Arabia's ambitious initiatives to remake the country's healthcare system, so many opportunities exist for foreign investors and Saudis alike in areas that will encourage and indeed enable the sector's success. These include 4 that we will focus on today, namely training and education of healthcare professionals, information and communication technology, private medical insurance, and performance management of healthcare facilities. I know it's late, and we're anxious to get on with it, so I will keep it short and sweet. And without further ado, I'll introduce our first panelist, Dr. Al-Yamani. Yamani, sorry.
Thanks, Charles. Good afternoon, ladies and gentlemen. It's my great pleasure and honor to be here, and I thank the organizing committee for inviting me to this forum. I'm going to talk a little bit about King Fahd Medical City and its role in the healthcare ecosystem in Saudi Arabia. And then I'm going to shed some light on the experience of King Fahd Medical City in public-private partnerships. And then I'll give a little bit of demographics on the healthcare system in Saudi Arabia and where the shortages are and where would be the right investment for investors to think about. How do we advance this? Here we are. King Fahd Medical City is a tertiary care organization that started back in 2004 and started gradually to become eventually the largest tertiary care organization under the Ministry of Health in 2005, between 2005 and 2015. Recently, King Fahd Medical City was asked to move beyond its scope, so from being an isolated tertiary care referral center to become an accountable care organization that looks after a population. But in addition to that, also look at or continue to cater for tertiary care patients who are from outside the zone or the designated zone. It's a about 1,200 bed hospital now with 8 medical centers or hospitals and a medical school within the facility. It's a total capacity of or total number of employees of about 7,500 in addition to some of the outsourced services. The clinical services are or the competencies of King Fahd Medical Cities were built around the deficiencies in Saudi Arabia. So it's neuroscience, cardiac, oncology, rehab, and comprehensive cancer. King Fahd Medical City is a training organization, so we train a huge number of residents. We train about 460 some residents per year, in addition to about 170 or close to 170 fellows. We have a number of diploma programs, and we also have master programs in partnership with international universities. We have a medical school that was closed for about a year plus, and now we're resuming that, and we are about to start a nursing school as well, given the shortage. As I said earlier, the task that is put in front of KFMC is to find the path for accountable care organizations, and we're working along the Vision Realization Office at the Ministry of Health to establish an accountable care organization. We're looking at different existing ACOs in the world to see which one would be the right model, and then redesign that to fit the culture of Saudi Arabia and to fit the system in Saudi Arabia. So we're looking at being a value-based population management system. We're looking at continuing to provide tertiary care out of the zone, and continuing on providing medical training and education. We continue to be a research center with a huge number of IRBs approved every year. And we'll continue to optimize the utilization of resources so that we can have a better value in return for the dollar. And we will also help in building the system, the healthcare system, in the new form. One of our existing examples of public-private partnerships is building the proton beam. And we've built that in a PPP form with a local company and an international company. And it's the only facility in the Middle East. It's about $250 million project. And it's a partnership of about 24 years. That started about 3 years ago. And it's going to start the first patient treated in January of 2018. It will be jointly operated between King Fahd Medical City and the private sector. That's an example of an existing PPP. Another example of a PPP is what we have with GE, which is the Health Staff Training Institute, and that is an endeavor that we started about 4 years ago, or less than 4 years ago, and over the 3.5 years almost, we trained about 10,000 healthcare providers in the different parts and different sectors of healthcare. It's jointly operated between King Fahd Medical City and GE, and its ultimate capacity is about 60,000 trainees per year, and we're working our way towards that, hoping that we will get there in about a couple of years' time. Now, you might have seen the map quite a bit today. This is where Saudi Arabia is on the globe. And then if we zoom up a little bit, there are the 5 different big zones, and then the 13 regions of Saudi Arabia, and the population is a bit different, the densities are different, and population growth rates are a bit different. Here are some demographics about Saudi Arabia, and what catches the eye here is if you look at the population growth rate, we're looking at about 2.4%. That's quite high. And if you look at the number of physicians per 1,000 population, it's about 1.1. Now, globally, a 1.5 is acceptable. But that is, when you talk about globality and number of physicians per 1,000 patients, you're talking about the rich and the poor, every country, and so on and so forth. But if you look at developed countries, you look at about 2 to 3 per 1,000, so we're quite behind in that. If you look at the life expectancy, we've managed to reach close to 75 years at birth. And when you look at healthcare expenditures, it's surprising. We're at 4.8% of GDP, which translates in actual figures per capita to 1,100 US per capita. Now, looking at that in the global market of healthcare, that seems quite low. But let me tell you what the secret is. The population is growing, and we're expected to be about 37 million in 2020. Well, if we're optimistic, it will be 35 million. We're about 31 now. We're at about 2.2 bed per 1,000 people. That's quite low. If you look at the average internationally, it's about 2.9. So no matter how many beds we build, more beds we build, the population is growing. So if you do the calculations, if you add 1,000 beds and do that over 3 or 4 years, you will be actually 1.9. And so that's where we need the private sector to invest, because the private sector has the leverage of doing it quickly. If you look at the history of healthcare in Saudi Arabia, it started back in the 30s with about 5 hospitals. Total capacity is 250 beds and 10 primary care centers. Today, we're at about 450 hospitals with a total bed capacity of 67,000 plus. And we're looking at about 80,000 in 2020. Look at that. The difference is about 13,000 beds. If you look at the 13,000 beds divided by the 37 million population, we will still be at 2.2 in 2020. So we're quite behind. We started again in the 70s with 1% Saudized jobs in healthcare, and we're about 43 now. And we started with 5 medical schools, or we started in 2002 we were about 5 medical schools, and now we're 26 medical schools with a total number of graduates of about 6,000. The disease burden, as was said all day today, is there is a surge in obesity and in diabetes, and that would eventually reflect into more cerebrovascular problems and cardiovascular problems. And again, we keep on saying and repeatedly saying that primary care is the way to go. And I agree with all said today that the infrastructure on primary care in Saudi Arabia today is quite low. It needs a lot of work. When you look at disease burden and DALYs, we haven't changed quite a bit. Maybe there are areas that look worse today, but that's only because there is more detection. We have improved a little bit in infant mortality rates. And if you look at the healthcare sector distribution in Saudi Arabia, you'll see that about 60% is covered by the Ministry of Health, 20%, about 20+% by the private sector, and 20% by the other government sectors. And that is on the 3 levels, primary, secondary, and tertiary. If you look at the bed capacity, the total bed capacity, as we said before, it's about 67. That's distributed between different sectors. And if you look at tertiary care out of that, you're looking at about 16,000 plus. Now, that simply means that we have focused more on tertiary care than where we need to focus, which is primary, and maybe a little more on secondary. If you look at our social progress in the global map, we're not too bad, even though we're considered to be more on the right side. We're supposed to be more a bit higher on that scale. But again, when you look at healthcare ranking, we ranked about number 26th out of 197 by WHO in 2000. We ranked about 16. We ranked exactly 16th by Bloomberg. But their indicators were a bit different. They're looking at efficiency of spending the dollar, and that's what I said before. We're at about 1,100 US per capita versus 9,500 in the States, and an average of about 5,000 in Europe. And that's why we ranked high. Because the Bloomberg looked at the number, at the expected life at birth, and they looked at how much is being spent for that, and the comprehensiveness of coverage when it comes to primary, secondary, and tertiary care. So a ranking is not that bad. But why are we worried? Why would we like the private sector to get in? Well, first of all, the private sector has the flexibility, so they can build faster and they can move faster. And then second is that if you look at the expenditures over the years on the graph that you see in front of you, even though the percentage of GDP hasn't changed, but because GDP changed, we have doubled and quadrupled the amount of money spent on healthcare, and that is the worry. The worry is that we get at a point where we supersede the 5,000 US in Europe or something similar. Now, the other thing is if you look at the purchasing power parity of the Saudi riyal, it's about 2.2 compared to the US as a national currency unit. So the 1,100 actually means 2,400. It simply means 2,400 US dollar being spent on healthcare in Saudi Arabia. And this slide reflects that quite well. If you look to the left side, we seem quite low. We're the first one on the left side, the first column, and we seem quite low at about 1,100. But if you do the purchase power parity, we'll get close to Europe. So that's the worry. That's why we're moving. That's why we're making this move towards maximizing utilization, using the private sector agility and the private sector know-how on how to maximize utilization, how to provide services in a better way. This is the existing healthcare ecosystem where you see the Ministry of Health being a regulator as well as a provider. And you see a number of providers that have nothing in common. And then this is the number of providers, and the shapes represent the size of the provision. So Ministry of Health is at 60%. And then you have Ministry of Defense, Ministry of National Guard, private sector, King Faisal Specialist Hospital, and the university hospitals. This is the proposed healthcare ecosystem where the patient becomes the center of the matter. The regulators are on one side, the providers are on one side, and the payers are on the third side. And there could be more than one payer. It's the private sector, the Ministry of Health, the fund, name it. And then you have the regulatory bodies, and as you see in the regulatory bodies, there will be an NIH and a CDC, in addition to the Healthcare Insurance Council and the Saudi Health Council, SFDA, and so on. The landmark here is that the part that was being done by the Ministry of Health before is now being, or will be done by corporates that will spin off the Ministry of Health. And they will definitely have to have some partnership with the private sector in order to fill gaps, salvage in areas where they have weakness, and leverage in areas where they can do more. This is the gap of Saudi healthcare when it comes to workforce. And you can see that in nursing, we're about 100,000 below, and we need to build that. In physicians, we're about 37,000. And that's taking Saudis and non-Saudis combined. So we're not talking about a gap in Saudization, but a gap in provision of healthcare. Technologists, about 68,000, and administrators, less than 1,000. I'm going to skip that slide because it's just going to do the comparison of the GDP that I've talked about. The key message here is that for these corporates to work at Ministry of Health, there has to be participation from the private sector. There are areas that we're working on now, like for example, we're working on spinning off radiology out of King Fahd Medical City to be a standalone company, and that will sell services to King Fahd Medical City as well as other hospitals. And there is a lot of need for technology, for workforce, and for expediting processes. We're thinking about doing the same with the laboratory, so it becomes a centralized a non-for-profit laboratory, and so on and so forth. Or it could even be a for-profit venture. It's a journey. We're going to learn as we move, and it will be quite a bit of a journey. And it's quite challenging to move from a totally public system to a non-for-profit private sector or non-for-profit government-based corporatization. The opportunities are tons for the private sector to be partners in this, and together we will build a healthcare model that we were hoping will be generalized across the globe, and we're hoping that this will be one of the best successful examples. Thank you very much for your attention.
Thank you, Dr. Al-Yamani. Your Excellencies, ladies and gentlemen, it's a privilege to be here today. My name is Laurent Dubois. I'm leading GE Healthcare Partners, which is our global healthcare technology solutions and consulting business. We work extensively, pretty much across the globe, mainly on the digital and solutions front, to help some of our major clients in their transformation journeys. We do this by leveraging all the technologies, the capabilities we find at the GE store across the broader GE. We take risk in doing so, and we assemble essentially and deliver those solutions to our clients. We have also worked extensively in the Kingdom over the last few years, and I'd like to share some thoughts today on our perspective on the healthcare transformation in the Kingdom, especially on the digital front, and on what it feels like to be a partner to this transformation. As we heard throughout the day, Vision 2030 is setting the bar pretty high indeed in terms of expectations for the transformation of the Saudi healthcare sector. As we also heard, the Kingdom is actually launching a vast number of initiatives to enable this. We heard about further plans to expand the infrastructure, think differently about infrastructure. We heard about outcomes and outsourcing. We heard about stepping up significantly the size of the local talent pool in healthcare, building capabilities, importing some of the best medical practices out there, especially from the US. And we also heard about very aggressive plans to digitize the Saudi healthcare system. We at GE had the privilege to work quite extensively over the last 9 years or so across the Kingdom on transformational initiatives, delivering tangible impact, working in very close relationship with the Ministry of Health and various other stakeholders in the market. Our teams have been working on the ground together with their teams to improve access, maximize capacity, step up patient safety, make a difference on patient experience, or reduce costs. We worked in over 50 hospitals and so have a pretty good feel of the state of the transformation across the Kingdom today. We're especially impressed by the potential for transformation, by the appetite for transformation, and by actually the early impact that we start to see from ongoing efforts. To take some simple example, if you look at what's happening today in the eastern region and in the Dammam area, which is one of the first areas in place in Saudi where we really see the vision for the new model of care starting to come together, becoming a reality, a more patient-centric model of care, integrating the model across the continuum. We see massive impact in terms of the ability to change things, to shift where patients are treated, and make a significant impact in the end on the access, the cost, and the quality of care. But there is obviously only so far you can go in driving transformation at scale in healthcare without addressing digitization. And when we think about digitizing the system, I think we think about it in terms of different components. Some are quite foundational, like the unified medical record that we discussed today, but there are also other more foundational components that the Kingdom is actively investing in, like device connectivity, workflow and department solutions, imaging solutions, just to name a few. Those are all very critical and foundational elements of digitization and offer plenty of opportunities to partner. We have also seen, however, around the globe that merely investing in those technologies as such do not generate the expected transformational impact on cost, quality, and access that we expect. Many industry leaders tell me that they actually fail to demonstrate simply the impact of a lot of the major digital investments that they have made over time. I actually expect that most of the transformational impact from digitization will come with the next wave of digital solutions, those going beyond the foundational elements. Operational, I'm talking about operation and clinical applications, tapping into data generated by those foundational systems. I'm thinking of leveraging sophisticated predictive analytics, artificial intelligence, deep learning, and the power of the clouds. And those applications will be transformation because they really enable a transformation in depth of the system, enabling some of the things that we discussed today. They allow healthcare system to become more proactive, both on the clinical and the operation sides. They allow to operate truly as a system at the level of a hospital or an entire region, instead of a collection of silos, and they enhance clinical decision-making. And ultimately, those will be the technologies in our minds that will allow to break through existing care paradigms. More advanced healthcare systems, like in the US or Europe, are basically, at this stage, I think, just starting to move into that space. And a significant part of the challenge lies beyond the technology. It's actually about changing the governance, changing the incentives, rethinking how those systems operate, building capabilities. Just a few examples of what we're doing on this front in GE Healthcare. Digital has really become a horizontal capability for us across all of our modalities and businesses, focused on solving key challenges faced by our clients, providers, and ultimately for the benefit of patients. If you think about the clinical side, we're working on applications to increase the speed and quality of processing and interpreting clinical data and images. Those have the potential to be transformational in terms, for instance, of quality of diagnostic, of the sheer capacity we have to treat patients and to treat and to process diagnostics. They're powerful device or organ-specific apps that can help spot pathologies faster, act more accurately, and in the end, enable physicians to respond faster and more effectively. If you think about the operational side of things, interestingly, I think healthcare is actually one of the most complex industries out there. Yet, when you think about the sophistication of how we manage operational complexity in healthcare, it's nowhere near the sophistication that we put into the clinical side of things. And actually, it's probably way beyond where other industries are today. If you think about the complexity, it's really mind-boggling. Take a single hospital. You talk about thousands of patients coming in every day, half of them probably unannounced through emergencies. We're typically talking about thousands of possible pathways. And in the end, we talk about tens of thousands of moments of care, moments of truth every single day, where all of that needs to come together with professionals, patients, equipment, infrastructure to deliver the promise of care. Yet, despite this complexity, today, most hospitals, most systems typically manage this complexity in some pretty siloed way. They're trying to optimize, each silo is basically trying to optimize its share of the game based on partial information. The result is very inefficient use of available capacity, reactive approach to events, redundancy across the system, risk to patient safety, and in the end, a lot of permanent heroics from staff to deliver care. That's why we're now working with clients to build digital care coordination centers, essentially command centers for healthcare, enabling them to operate truly as a system. They provide the required system-wide transparency by listening to, in real time, to dozen of different systems. They're coming with a number of apps addressing specific pain points across the system, powered by a digital twin of the hospital, allowing to understand the impact of simple decisions on the overall efficiency and capacity of the system, and able to predict bottlenecks up to 48 hours in advance, just knowing which patients are where based on specific indications. We have delivered the first of this new kind of coordination centers last year at Johns Hopkins, and that enabled them to fundamentally unlock significant capacity while reducing holds and inefficiency across the system. We're now working with different clients across the globe to deliver similar centers, and we're in active discussions to engage in similar projects in Saudi. What does this all mean for the Saudi transformation agenda when you step back? I think based on our experience on the ground, although humble in scale compared to what's coming, we at GE strongly believe in the Vision 2030 of the kingdom. We also believe that by investing in key enablers, as the kingdom is doing today, it will enable that transformation at scale. especially with a bold approach to digitization, investing both in foundational components and transformational applications. The Kingdom has the potential actually to be at the forefront of building a more sustainable and more integrated healthcare system than what we know in many other countries, and to leapfrog its development on many dimensions. It's a very exciting place to be as a partner. It's a very exciting journey that we're engaging and that we're part of, and we're proud to be part of it. We're confident in the partnership opportunities, and as Jeff Immelt mentioned this morning, we're massively investing to help accelerate this and be part of this story. Thank you.
Good afternoon, Your Excellencies, ladies and gentlemen, friends and colleagues. I'm both grateful and very honored to be in this congregation today to talk about two areas that are very near and dear to my heart, accreditation standards and then reporting on hospital metrics in the Kingdom. I'd like to start with a brief talk about the historical evolution of accreditation in Saudi Arabia. It's very important to point out that Saudi Arabia has been one of the earliest adopters, if not the earliest adopter of hospital accreditation, not only in the Arab world, but internationally as well. The first hospital to be JCI accredited in Saudi Arabia was King Faisal Specialist Hospital and Research Center in Riyadh, and that was back in 2000. Joint Commission International has only been created in 1998, so that gives you an idea of how early of an adoption Saudi Arabia took in that regard. And then if we move on to the hospitals under the MOH, the first hospital under the MOH to be accredited was King Khalid Specialist Eye Hospital. That was back in 2011. And then the first multi-service hospital under the MOH to be JCI accredited was King Fahad Specialist Hospital in Dammam. I'm very privileged to work there, and that was back in 2010. Today, there are 79 hospitals across the Kingdom that are JCI accredited. And in recent years, there's been a huge advancement in developing the national standards for hospital accreditation, known as the Central Board for Accreditation of Healthcare Institutions, or CBAHI for short. Has been gaining a real momentum in terms of establishing expectations for patient safety and quality standards across the Kingdom. Just to give you an idea or a comparison of sorts, if we talk about patient safety, and we talk about the standards that address patient safety in JCI, there are 6 distinct standards that talk about patient safety. In CBAHI, those were increased to 20, what they call Essential Safety Requirements, or ESRs. And there has been a clear mandate from His Excellency the Minister that there is an expectation for all hospitals, regardless of their affiliation, to be fully CBAHI accredited by 2018. And there has been a lot of work around the compliance to these essential safety requirements, and in essence, a compliance to patient safety standards. And hospitals now, as we speak, are being scored or graded on how well they comply to these standards. There was a first wave of surveys that was done by CBAHI to all hospitals in the Kingdom. This was early last year. And the grades were out, and it's basically based on a composite risk score. So this score looks at elements of patient safety, elements of staff safety and facility safety, and in essence, hospitals are scored based on how well they comply to these ESRs. You're in the green zone if you're a low-risk organization, you're in the yellow zone if you're a moderate-risk organization, and you're in the red zone if you are a high-risk organization. And after that, there was also an even clearer mandate from the ministry and His Excellency the Minister to have an expectation that by the second wave of ESR surveys, which are happening as we speak back home, the expectation is for every hospital to move up at least one grade. So that, for the first time, has put patient safety in the forefront, and we are able to now speak about patient safety objectively, using numbers and well-thought-of comparisons. The ministry has also been taking strides in terms of clinical risk management. And some of you may know that there is an electronic portal that was developed by the ministry years ago, And the expectation is any hospital, whatever their affiliation in the kingdom, if a sentinel event takes place, the expectation is within 24 hours that has to be logged into the portal. And then within a defined expectation of time, if a report on root cause analysis is done, it needs to be uploaded as well. That portal is a wealth of information. It's a treasure trove for anybody who wants to really understand patient safety and the risks and the violations that take place and what kind of trends and what kind of risk categorization do we have in the kingdom. And as the ministry is moving on with the National Transformation Plan and taking more of a regulatory role rather than a provider role, there's going to be even more emphasis on releasing this information. And again, very valuable information to us as healthcare workers and leaders to understand where patient safety violations happen, how they happen, what kind of action plans has taken place to mitigate them, what works, what doesn't work. So that's all, it falls into that bucket of creating a culture of reporting, whether it's reporting on metrics or reporting on errors wherever they happen. And we've seen it before our eyes. The culture of reporting has been dormant for many years. And now we're seeing, with this transformation, a kind of a renaissance of reporting. And if I take you through reporting on hospital metrics or how hospitals report on their efficiencies, there's now an expectation in the ministry for every hospital to report on basic metrics of operational metrics, utilization metrics. These are weekly, some of them are monthly. This is happening for the first time. And although they're basic in nature, but it is a starting point. Other areas in terms of metrics or reporting on hospital performance, which is quite a new development, and I'd like to share it with you today. You've all heard of some of the panelists, the creation of the medical city boards. There are 5 distinct medical city boards that are now launched. And there has been, right now, just putting the final touches on a group of board KPIs that are expected to be reported up to each of these medical city boards, and then eventually across. And these KPIs have been well validated, well defined, well studied, and they're a healthy mix of strategic, operational, utilization, for the first time, clinical-based outcomes, research, financial mix of KPIs. And ultimately, these are going to be reported up to these boards. And the idea is also to report across the boards. And this is going to be really, for the first time ever, the nucleus for the creation of validated, evidence-based national benchmarking. We've been talking about that for many years, but I think now, with the creation of the corporatization of these medical city boards and the move of the ministry to move into more of a regulatory role, a heavy emphasis is now being put on creating real, valid national benchmarking. And in the true sense, we will be able to reach a point where we are comparing apples to apples. And largely that's across the medical cities. It's very exciting, and I hope that next year, if this congregation takes place, we'll be able to come back and report on these metrics and how well we were able to envision them and then see them go into light. By that, I'm just going to have to finish off by saying that there is a clear movement from the ministry of creating this culture of reporting. And we see it every day for us that work in the ministry and work in hospitals under the ministry. It's a point in which this culture is created and people are now more comfortable with seeing results, more comfortable with having dashboards reported and shared. And I think that will be of great value for investors, for payers, because we know that the future payers are no longer going to be the government. So that definitely creates a sense of having an informed payer, ultimately, and even more importantly, having an informed consumer of healthcare. Because it's not unusual to expect that at some point there will be public reporting on measures, whether they are hospital measures or even if they're provider measures. And that's something that we hope to see, inshallah, in the near future. And I'd like to thank you for your time.
Good afternoon, everyone. I thought since the conference is about investing in Saudi Arabia, investing in new healthcare systems, to share with you my own personal experience in investing in healthcare, investing in Saudi, investing in a new healthcare system 20 years ago. 20 years ago, our family wasn't in business. My father was in the public sector. Me, my older brother wanted to start a business. And my older brother was in the construction business. We had a lot of challenges in relation to collections and receivables. So we decided we wanted to get into the business where you get your cash up front. True story. So that was our criteria. And during that time, reading in newspapers, conferences like this, that the Minister of Health wanted to introduce mandatory health insurance for the private sector. 20 years ago, the system in Saudi was basically free healthcare for everyone, whether it is private or public. So that was the criteria. It was in a conference like this, listening that health insurance is going to become mandatory in Saudi. We looked at insurance. Well, insurance, you get your cash up front, so fits within our criteria. Started looking for international partners to help us out. And we found a company that is called Bupa, which is one of the largest healthcare players in the world. At that time, even Bupa itself weren't an international company. So we talked to them about listening. The regulators are coming with this law. Why don't we invest together in Saudi? And we were their first business partner in the world. So we started the business, and I still remember till this day, during that time I was applying to business school here at Wharton, and my actual application, and I still say it to this day, I host all the basically new applicants and alumni every year. My actual application to Wharton was, listen, we're creating a company called Bupa, an insurance company. They ask you, they have this question is, why should we accept you? And I was basically saying, listen, I have no idea about healthcare, no idea about insurance, but we're starting this company and I need to get the education to run this company. That was my actual application, and they accepted me. So basically we started the company. I see the regulator is in front of me during that time, and we've heard everything that insurance will not work, the private sector is not ready for it, there is no capacity, there is not enough private hospitals in Saudi, there is no way it's going to work. And my experience, once you create the regulations and you create the proper investment environment, investment will come. And basically there has been discussion before the regulation got implemented between the regulators and the insurance industry. And we're celebrating 20 years today. So the actual enforcement, we started the company in 1997. The actual enforcement started in 2008. 2008, the regulation, 2008, the actual enforcement. So it took us 2006. So the regulator is helping me with the numbers. So what we've had, and it was a big advantage of us, is that we knew it was gonna coming. We were extremely patient, so we got what you call first mover advantage. So a lot of learning how to deal with the hospitals. We made a lot of big mistakes during that time, but luckily, because we got in early, we made all our mistakes when the industry was small. When regulation came in, and you're talking a market that was less than 1 million customers, when the regulation came in, today there are around 12 million insured people in Saudi. and potentially by the end of this year, there's going to be around 15 million. Just to share with you a bit of the learning of the maturity of the insurance industry. I still remember when the regulation started, all our focus was on capacity. So basically investing in systems, making sure you have a big enough call center to handle customers. This is all what we did. And the competition during that time was about who can handle customers without their basically systems fall down. And that was our focus. We moved from purely just handling capacity to really start becoming innovative in basically dealing with the hospitals and the service and automating claims. We handle today around 20 million claims per year. And we're talking about, we've automated around 80–90% right now of the billing system. I remember during that time when the industry was growing, we had a theme in Bupa calling it the Million Man March. So when was the first company to handle the first 1 million customer? The industry matured from not only competing from a service, we became more involved in relation to what additional services we can provide our customers in addition to just paying claims. I'm with the personal opinion is that insurance by itself is a commodity business. Everyone can pay a claim. That's easy. It's how you win the customer and provide added value services. So the health insurance industry is starting to be matured, moving more from paying claims to becoming more innovative on healthcare services. I'll just share with you some numbers. In 2016, we gave over 2 million healthcare services outside of paying claims, from chronic disease management to telemedicine to online medication. So the industry started to become a bit more mature. And there's still a lot to grow. So basically, the idea is that when you listen to regulators or ministry in Saudi that, listen, we're doing something, I've actually witnessed it in relation to being in a room like this where the government is keen to change a system. We've gone through it, and we've experienced it, and we've done extremely well in it, where today we have a turnover of over $2 billion. We have around 3.5 million customers. What is exciting to me today is that not what we've achieved, but what is the potential of the healthcare industry in Saudi and what we're hearing today. And I'm seeing a lot of opportunities. I'm seeing a lot of opportunities within the insurance sector, the health insurance in particular, where I believe yesterday in a TV interview, the Deputy Crown Prince said that there's going to be health insurance for every Saudi. So if you're talking about there is around 12 million insured right now, that potentially can go up to 30 million. That's a huge market, and it's going to be interesting to see what would the role be for health insurance companies, whether as an insurer or as a TPA. The other big opportunity is that when you're hearing the Ministry of Health saying that they want to increase private sector participation from 25 to around 35. So there are a lot of huge opportunities in relation to PPP. And I know we in Bupa are very much interested in relation to primary care. And you're probably hearing a big theme around primary care. But it's not only about the systems. When I actually look at the data and we pay for a lot of claims, the Saudi population is a very young population. 97% of the claims that we pay for are outpatient related. that actually our customers don't need to get treated in the hospital, it could be in the primary care. So we see a lot of huge opportunities in primary care. And then basically the third leg is that for the private sector, once there is insurance, once there are more private sector hospitals, there is a lot of opportunities from wellness businesses to a lot of IT related, from billing. Can you change the billing system in Saudi from fee-for-service to payment on outcome? So it's an exciting opportunity. It's a huge industry. The size of the health insurance market today in Saudi is around $10 billion, and it's probably going to double in the next 5 years. So a lot of opportunities, a lot of excitement. You just need to be a bit aggressive, take a bit of risk, and Saudi is a great country to be in, specifically in healthcare. And thank you.
Dr. Rana, gentlemen, thank you so much. Fascinating presentations. I'm not sure how we squeezed those very, very different topics all onto one panel, but it's testament to the sort of the varied aspects of this sector and of this initiative. We have some questions, or I have some questions I'd like to ask, but I'm more interested in hearing what questions the audience might have, and I'll encourage you to be as lively and controversial as you'd like. It's the end of the day, so may as well get it out now. The gentleman back there. Yes, thank you.
Assalamu alaikum. Thank you for organizing this. My name is Said Al-Bezri. I'm a local doctor here. Question for Dr. Yamani primarily. When we talk about privatization and the Ministry of Health moving from being an actual operator to an organizer and maybe like an oversight organization, what are you expecting from healthcare providers here in the U.S.? So if I'm a healthcare system, if I have a healthcare network where I take care of patients here, being a hospital or a manager of a group of hospitals, what do you expect from us? Do you expect that we come in and do the Johns Hopkins kind of a JV setup? Do you expect that we bring a C-suite of top executives to manage an operation? Can you be a little bit more specific on the options that you have in mind for operators here in the U.S. On what is the business model that you're thinking of? And the second thing, are you open to some sort of consortiums where U.S. healthcare system can provide some services that we're good at, so like the top executives and some niche, highly complicated services, and then we collaborate with another healthcare system, either in like private sector in Saudi or maybe in the region. I mean, you have excellent countries around where they can provide labor force, say Turkey, Jordan, Egypt, and provide like a consortium where we can come with a turnkey solution rather than just a partial solution. Thank you.
Sure. Thank you very much for the question. The spectrum is quite wide. It depends on every organization and what is it that they need. So there are organizations that would need expertise in, for example, building revenue cycle management. Others would need expertise in running primary care altogether. We're talking about anywhere between 5 and 25 corporates of healthcare in the whole country. Starting with about 5 and then building up, and we may even reach about 30 corporates. Every corporate will have its own needs, and so there are corporates that would need C-suite employees. There are corporates that would need taking a chunk of the population to manage. There are corporates that would need intervention in certain areas, and as I mentioned earlier, primary care would be one example. And then there is also the consortia, and I think medicine is very close to aviation in a way. And a friend of mine had told me once, look at what aviation done. You have companies that will handle the luggage, you have companies that will handle the catering, companies that will handle the booking, and the customer doesn't know about any of this. I mean, you get your ticket online and you reach your destination not knowing that there are about 50 companies that have handled you from Boston to Lahore, for instance, or to Riyadh. Now, that needs to be built into the healthcare system in a way where the customer does not need to feel that. The customer should not feel that there is more than one party. They go to King Fahd Medical City as a corporate, that's where they get treated. But they don't know that there are within KFMC a number of partners. And we've done that. We've started on that with Proton Beam. We've started on that with the GE, the Healthcare Institute, Training Institute, where we started that with laundry, and we have a company that runs the laundry in a partnership with KFMC. We do about 50% of the hospital laundries in Riyadh within KFMC in a partnership with somebody that runs the laundry service. We're planning on spinning off radiology the same way, the lab the same way. And so eventually what happens is that you have multiple companies that work along with the corporate to deliver the service according to certain metrics and certain standards. And we will be an accountable organization. The patient will only see one logo. So what do we need from North American companies, US companies, international companies, is wherever they can help, where their areas of strength match the areas of needs in the corporates, that would be an opportunity. And I'll tell you, one example is in King Fahd Medical City, we are starting to build the revenue cycle management. We don't have the expertise. There are local and international companies that can do that. And we're more than happy to start with these companies so that we can build the revenue cycle management together. They get a portion of the income. We get the know-how over time, and so on and so forth. Did I answer your question? Thank you.
Please. Yes, second row.
Assalamu alaikum, Dr. Ahmed Al-Tayyar. I'm a Saudi physician who's working for Johns Hopkins Aramco Healthcare, currently doing a master's at MIT in system design and management. Thank you very much for all the panelists. So I'm just going to give a few statements and then a question open to all. First of all, the healthcare system is a complex system. I think we agree on that. Therefore, a lot of the solutions that are proposed are usually simple solutions to a complex problem, which really doesn't make sense. You need to simplify the complexity, and then you have a simple solution to a simple problem. The second thing is the mention of the financial aspect. So a lot of the readings that I've been doing recently kind of indicate that financial health surpasses like the physical health with regards to immediate needs. So if we think, if I tell somebody your disease or your lifestyle is going to affect you in like 10, 20 years from now, they're less likely to make changes in comparison to telling them, listen, it's going to affect your pocket right now. That's a separate statement altogether. The third statement that I'd like to bring is the importance of integrating the different components of any system. So just having the best components without appropriate integration and looking what each of these components, how they function and how they affect other components is a huge loss to the outcomes of the system, the possible outcomes of the system. So my question to the panel is, how, and again, I'm not expecting a simple answer, or one answer. I don't think any of you believe that there's a single root cause for the healthcare challenges that we're having. So since we have multiple factors, what are multiple approaches and how can we integrate these potential solutions all together to solve the healthcare challenges that we have in the kingdom? Thank you.
Thank you very much. Well, I did invite controversy. Anyone here want to take a stab at it to begin with?
I'll take a crack at it. I mean, when you look at some of the major challenges in Saudi and the healthcare. You probably talk about diabetes. You talk about there's not a lot of what you call gatekeeping program, so the cost is high. You have a young population that if you don't make it healthy today, we're going to see an accelerated cost in the next 5 to 10 years, because once this young population that is not healthy get older, the cost is going to be humongous. So to me, it's not about healthcare systems, but it's what can you invest today? And to me, I see no choice, and the Ministry of Health is heading that way, but to invest in primary care. Because I think primary care sort out a lot of these solutions. It becomes a gatekeeping. It will invest a lot in the communities and wellness and all of that. And it will save costs in the long run. So to me, it's more simplifying it. So what are the hot areas for the Ministry of Health to focus on, to basically to bend the curve? And to me, one of the key areas is investing in primary care.
I'd like to piggyback on what Tal just mentioned, and from the perspective of a person that works in a specialty hospital under the MOH. We've been existing and working in silos forever. And we understand that the problems that we face today is patients that come with very advanced disease progression, patients that come when it's really too late. And the only solution, and it's not a simple solution, is accountable care organizations in which you are responsible for population health of a certain population, and it is the entire spectrum of healthcare. So you get them from primary care and measuring their blood sugar and taking care of their weight and smoking cessation and everything that's good and healthy for them, and then across the spectrum until you reach, if need, specialized healthcare. But the current ecosystem as it is, it cannot exist, because we will continue to live and work in silos, and that's only going to be more expensive and more disparate.
I think two observations building further on what you said. I think one, in terms of change in healthcare, I think if you look at other sectors, people change behavior when you have a very solid financial impact, to your point. I don't think we're there yet. I think many systems are actually quite forgiving in terms of behavior. I think if you look at the changes that were achieved in, for instance, road behavior in some countries, until things become very punitive somehow, and the risk has become very significant, people just don't change behavior. I think the shift that we see to private insurance, to copay in many places, will drive a lot of change in behavior, increasingly over time, but it will take time for people to realize that. And it's not only patients, it's also the incentives in the system in terms of physicians, providers, and what is attractive to them, what procedures are attractive to them, how it's attractive for them to treat patients. I think on something else that you mentioned, simplifying the complexity of the system, I definitely agree with the mindset and trying to go there. I think, however, healthcare is just one of the most complex industries I've seen, and I worked across probably 15 different industries. And you cannot simplify that to the point where we can manage it with the tools we have today. I think, on the other hand, the level of sophistication that we have in healthcare in terms of managing that complexity is just very basic, again, when you compare it to other industries. And so I think there is a lot more we can do in terms of getting transparency of data, working across silos. It takes governance, it takes different incentives, it takes capabilities, it takes digital capabilities. But there is really a way to basically manage that much better, being much more proactive about it, and just trying to understand. Instead, we're fundamentally managing healthcare as if O'Hare in Chicago was trying to manage the 9 runways they have based on the flight plan they do the last day, and then hoping everything will go according to plan. And that is just not like this. And today we don't have the transparency to understand that things need to move in a system, that patient is late, and therefore actually, something 3 levels down the line, we should also shift something else. I think that is what will create a step change in operation capacity and efficiency.
Yeah, an interesting question. I guess one of the major problems we have back home today, and going back to Rana's point, is the lack of integration. Even when we gave primary care an attempt back in the 90s, it was a failure because it was not integrated. And I think defining a population for a responsible organization to look after, as challenging as it is from a financial aspect, what keeps me up at night now is the financial risk of this upcoming ACO, because one patient could just screw the whole system. Yet, that would guarantee you an integrated system where the patient is cared for from, not only from cradle to grave, but rather from inception to grave. And then and only then, the organization will be keen, all organizations will be keen on keeping patients on the right side of the spectrum of disease, i.e. on the healthy side of spectrum, rather than if you are an encounter-based organization where you want to get, where your benefit is more on the left. So that is very promising when it comes to the long term. Now, that said, it's going to be a chaos in the first while. I'll tell you that the first decade, a lot of people will turn up tons of gray hair out of this. But it's a challenge that we should all take because we're not looking at 10 years down the road, we're looking at 50 years down the road and where we're going to be.
And I don't know if the moderator is allowed to chime in response to a question, but I'll add 2 cents if you'll allow me, which is I've been advising companies looking at Saudi Arabia, going into Saudi Arabia for a better part of 20 years now. And you really do feel something is very different today. And yes, it may be a complex problem, but there's an appreciation of the complexity and a real commitment to negotiating around the complexity. So from that perspective of an advisor to companies, I really do see that. We have time for one more question. Please, gentleman in the front row.
Thank you. Tariq Al-Qasabi. My question to Mr. Laurent of GE, could you please elaborate in GE plans on transfer of technology to Saudi Arabia and Saudization? Because I have not noticed any Saudi from your team, GE Medical. Thank you.
Okay. So we're investing as GE across all sectors in localizing production, as Jeff Immelt explained this morning. In healthcare especially, we're also moving part of our production in imaging locally. In terms of our workforce locally, we're increasing and building that workforce out. We have many Saudis, and I definitely hope that we can find some in the room here to introduce to you. But this is a core priority for us to have local capabilities. You cannot succeed in Saudi if you don't go local. I don't believe that. So most of our resource, actually local resource. We do have also a few resources from across the region, but we have very few expats operating for us in the region.
Okay, time for one more question. This gentleman here, please.
My name is Tony Tenori. I'm a spine surgeon and specialize in minimally invasive spine. I do visit the entire Gulf region and also Saudi Arabia, and I'm asking this question from the prism of a visiting surgeon. And I find that I visit very, very well-equipped, prestigious centers in the region. And here's my observation and my question. I find that all these centers, they have all the right items there in place, but the lowest pay bracket and that servicing is somehow missing. I can do 6 surgeries in my OR room here, and I can do only 2 at best when I visit elsewhere. And if I look at where is that breakdown, where the bottleneck, it's not the surgeons, it's not the O-arm, it's not the latest and the greatest. It's basically just cleaning the room. or like getting a patient in and out of in the clinic to see the next patient in a clinic. So a lot of, I think, yes, it's beautiful to work at the bigger picture, but I do really think that there's a lot of opportunity here in servicing, and you can really make the system a lot more efficient that way. I would like to hear your comments.
May I? I guess part of that goes back to the existing governance system where the healthcare providers are not incentivized to produce more. Everybody is on salaries. And you see the same person at a public hospital producing about 20% of what they produce in a private hospital at the same time. And the idea here is that if you don't link the incentives to productivity and outcomes and quality of outcomes, you're not going to move. And that is one of the first proposals in changing the governance. Once organizations are paid for keeping the population healthy, and then organizations do pay their own employees on, again, keeping their patients healthy, but also doing the maximum that they can do with the best possible quality and outcome, then and only then you'll see change in the volume. We've done a lot of efforts over the last 3 or 4 years in trying to maximize, and I'll give you examples of that. We used to see about 250,000 patients in outpatient clinics over about a year of hard work and getting the buy-in from clinicians. We raised that about 400,000, and it's going to be 500,000 this year. So over about 4 years, we doubled up the number of visits in outpatient clinics. We're looking at major operations, and we move by about 20% over about a year time. And so the ultimate objective is that you can squeeze from the existing system the way it is, but you can't increase by folds unless you change the governance, unless you change the way you reward performers and get out of the quote-unquote social system where everybody's paid salaries.
I'd like to add to Dr. Mahmoud's point, in addition to having incentives, I really do appreciate your comment. And I can just give you a very small example of what we did in our hospital, and that's the power of data. And going back to your example of OR utilization, we've looked at that area, and what we've done differently is started to publicly report on, in a daily basis, OR utilization, OR cancellation, turnaround times, first case start on time. And the power of having this data public creates a sense of synergy and energy within that group without adding anything else to the mix. We've seen our OR utilization goes up. We've seen our first case start on time go up. We've seen our cancellation go down just by the power of publicly reporting on the data. And I think that can be replicated in other areas in healthcare where you have those inefficiencies.
I think that's it. I think we're out of time. I'd like to thank the panelists so much. And on behalf of the panelists, I'd like to thank you for having us. Thank you, ladies and gentlemen, excellencies.
Ladies and gentlemen, I want to introduce our last speaker of the day. So if you could just bear with us, I'm sure that you will find the remarks upcoming worth your time. So I would like to introduce to you Dr. Reem Fahad Bunyan to give closing remarks to our conference. Dr. Bunyan is the Executive Director of Medical and Clinical Affairs and Consultant Neurologist at King Fahad Specialist Hospital in Dammam. Dr. Bunyan received her medical degree from King Faisal University, where she graduated with honors and earned the Prince Mohammed bin Fahad Award for Academic Excellence. She acquired her master's degree in biomedical sciences in clinical and translational research at the Mayo Clinic. She completed her residency in neurology at the University of Louisville, and she is president of the Saudi Multiple Sclerosis Advisory Group and a member of the founding board of the Healthcare Administration Club, and she led the Neurosciences Center at King Fahd Specialist Hospital in Dammam. Please welcome to the podium, and please give her your attention, Dr. Bunyan.
Assalamu alaikum. Good afternoon, everybody. I'd like to start with thanks to the organizers of this conference, with special thanks to Their Excellency, the Minister of Health and the Minister of Commerce. So I come at the end of a long day of a lot of discussion on potentials for investment in healthcare. And I come to you from the perspective of a leader of a hospital that's a tertiary care center, the only tertiary care center in the eastern region of the country, and one of the first developing clusters. In addition, I'm one of the 6 national leaders in the new model of care. I'm the national leader on the chronic disease system of care. I'll be repeating some of what you heard earlier in the day, and I'd like you to go home with the soul of what's happening in the transformation in healthcare in the Kingdom of Saudi Arabia. So my first slide is a happy slide. We've come a long way. So we've had a lot of successes, and you can look at the bottom side of the slide and you can see specifically our success in vaccination, and the other one is the success in life expectancy. The next slide is a not so happy slide, is the challenges that we're facing. And the challenges we're facing are mainly related to the epidemic of chronic diseases. Most of these chronic diseases relate to habits: eating, lack of exercise, smoking, etc. You've heard throughout the day many of these examples. If we don't do anything, we will not survive. This transformation is a must. It's not something that's optional that came to us that we just decided to do over the last year. It's something that we have to do. And if I were to spend the rest of my presentation, I'd just spend it on this one slide, because this is where we need to put our money: wellness, prevention, management of chronic diseases. So you've seen this slide before, and I put it back just to bring your attention to the core of all of the activities that are happening in the healthcare system transformation. The core of it is the model of care. It will drive everything else, including private sector participation and opportunities for investment. This slide shows the current model of care in comparison with where we would like to go. And you can see that the patient in the first box, in fact, I would have liked that patient to be outside the square. The patient isn't really in the core of our attention. And in the new model of care, the patient and the family is in the heart of our transformation. The patient and the family are the customer in this investment discussion. And this is the responsibility of both the public sector and the private sector. In this slide, I show the new model of care. The patient in the middle, with wellness that is physical, mental, and social. Again, if I were to stop, I would just stop here. And this is where all the efforts that we do need to be focused on activating, the label, an activated, empowered, informed patient. All of the investment opportunities that we are going to discuss need to be with the patient's perspective kept in mind. This does not yet exist. The customer in the Kingdom of Saudi Arabia is fairly sophisticated. And all the solutions that we need to come up with need to be tailored. They can't be ready-made solutions. They have to be created for our patients in our population. The next part is the community. This ring does not exist yet. And the next ring, virtual health, digital solutions that are in the patient's hand to use. These three rings don't yet exist in our healthcare system. The next one we've heard quite a bit about, primary care. Primary care needs to be redefined, basically. Needs to be redefined, needs to be redone. I heard some of the discussion earlier today about root cause analysis. That's not what we're doing. We don't need to fix what we did wrong. We need to redesign it. We need something new and different because what we did before is not working. We need something new. And the last ring is hospital care. Across all of these rings, we have our 6 systems of care: chronic disease, wellness, end of life, mother and child, urgent care. All of these systems, they cross through the entire healthcare system. That's the new model of care. So the exercise we went through in designing the new model of care was a bottom-up exercise. One of the audience asked that question earlier today. This was done bottom-up. Each of the 6 systems involved at least 50 subject matter experts from around the country, from the Ministry of Health, other sectors, including the private sector, and it also included patients and families who sat together and thought through about the problems that we have in our healthcare system, the gaps, the needs, and the appropriate solutions. These are the solutions. If we implement these solutions, we will end up with a healthcare system that is patient-centric, integrated, we heard about integration, efficient and accountable, private sector enabled, financially sustainable, and best practice informed. This is our objective, is to have innovative models of care that are structured around accountable care units responsible for population health. With this, we will have good access to care, good quality, and low cost. On my last slide, I'd like to just mention a few things that are special and unique about our health and healthcare system. We do not have a legacy system that we have to deal with, similar to many other countries. Our population is young. Our customer is sophisticated. We need solutions designed from the perspective of the customer. We need disruptive technology. The main focus is going to be on wellness and chronic disease management. With this, we will have an entirely new market. Thank you very much.
Thank you, Doctor. Ladies and gentlemen, that concludes our program for today. We thank you all for coming. We hope you found the day's content usable, and we hope the discussions that you've had will actually lead to business. So enjoy your evening. Thank you for coming.